Hi everybody, and welcome to our module on adrenal disorders. Adrenal disorders essentially fall into one of four categories. There are disorders caused by excess or insufficient cortisol, there are diseases of excess mineralocorticoids, and then finally there are tumors, and we'll talk about all four of these in this module now. When people have exposure to excess cortisol, they develop a characteristic set of clinical features known as Cushing's syndrome. And the most common reason this occurs is from patients taking corticosteroid medications. You'll routinely encounter patients on your clinical rotations who have Cushing's syndrome because they have been prescribed steroids for some inflammatory condition. For example, patients who are required to take prednisone every day to suppress their lupus will develop a Cushing's syndrome. Now, don't confuse Cushing's syndrome, which is a set of clinical features from excess cortisol, with Cushing's disease. Cushing's disease is a pituitary ACTH secreting tumor. Cushing's disease is one cause of Cushing's syndrome, but it's not the only cause, and as I said before, the most common cause is corticosteroid medications. Patients with Cushing's syndrome develop symptoms from excess cortisol, and I talk about the effects of cortisol in the module on the adrenal glands, and patients with Cushing's syndrome develop excessive effects of cortisol. So this includes hypertension, hyperglycemia. Patients with Cushing's syndrome develop diabetes from insulin resistance. Their immune system is suppressed, so there is a risk of infections, especially opportunistic infections. All of these things happen to patients who have Cushing's syndrome for any reason. Cortisol alters GnRH release from the pituitary, and this can lower the levels of the sex hormones. In women, this will lead to menstrual irregularities. These are very common in women who have Cushing's syndrome. About 80% will have abnormal menstrual cycles, about a third have oligomenorrhea, and a third will have amenorrhea. In addition, many women who have Cushing's syndrome develop hirsutism, which is hair on the face. And in men who have Cushing's syndrome, erectile dysfunction is very common, and all of this is related to the alteration of GnRH release. Excess cortisol will stimulate adipocytes, and this will lead to the growth of fatty tissue. Once you've seen a number of patients on chronic steroids, you will begin to recognize the pattern of fat deposition immediately whenever you meet a patient who has been taking steroids and has Cushing's syndrome. The characteristic fat pattern involves progressive central obesity. This is a picture of what someone might look like with Cushing's syndrome. You can see fatty tissue around the abdomen here. That's central obesity. In addition, there's fatty tissue deposition in the face, neck, trunk, and abdomen. One of the characteristic findings is called the moon face. This is a picture of a child who is taking steroids. You can see that his face is round like the moon. Another classic finding of Cushing's syndrome is called the buffalo hump. This is shown here in this picture. It's fat at the base of the neck in the back. Patients with Cushing's syndrome develop characteristic skin changes that you will be able to recognize once you've met a few patients on chronic steroids who have the Cushing's syndrome. They classically have thinning of the skin and easy bruising. This is usually easy to visualize by looking at their forearm. You will see that the skin is very thin and paper-like. There are often a number of bruises easily visible under the skin of the forearm. In addition, Cushing's syndrome causes striae, which are stretch marks usually on the abdomen. These are purple lines on the skin. They occur because the fragile skin stretches over the trunk, breasts, and abdomen, and the thin skin cannot hide venous blood in the dermis. Usually you see these in the abdomen, either below the umbilicus or on the sides of the abdomen. If you Google this, you can see lots of pictures of patients who have Cushing's syndrome and have dark purple striae on their abdomen. You can divide the causes of Cushing's syndrome into those that are ACTH independent. These are syndromes where the ACTH level is low but cortisol production is high, and into those where they are ACTH dependent. These are syndromes where something is secreting too much ACTH and the adrenal glands are responding as they should by producing more cortisol. The ACTH independent causes include glucocorticoid therapy and adrenal adenomas. When you are taking steroids for therapy, the ACTH level will be low, but Cushing's syndrome develops nevertheless because you are taking oral steroids every day. Patients with an adrenal adenoma have a portion of the adrenal gland secreting cortisol at an excess level. The ACTH level is low, but it's unable to dial down cortisol production in the independently functioning adenoma. ACTH-dependent causes include Cushing's disease, where there is a pituitary tumor secreting ACTH, or an ectopic source of ACTH, such as small cell lung cancer. Small cell lung cancer is a classic cause of ectopic ACTH production. In both of these situations, the ACTH level is high, the adrenal gland becomes stimulated, and it develops hyperplasia and grows in size, and this leads to increased cortisol production. Let me make a brief comment on skin hyperpigmentation. Skin hyperpigmentation essentially means looking as if you have a suntan, sort of like this man shown on the screen here. And this is classically associated with Addison's disease, which we'll talk about later, but you should be aware that it can occur in ACTH-dependent Cushing's syndrome. Basically, anytime the ACTH is high, that can lead to hyperpigmentation. That's because high ACTH increases the levels of melanocyte-stimulating hormone, which is MSH, and that's what leads to skin hyperpigmentation. So in ACTH-dependent forms of Cushing syndrome, the ACTH level is high, and therefore skin hyperpigmentation can occur. And later we'll talk about Addison's disease, and in Addison's disease, ACTH levels are also high. You might think that it would be easy to diagnose the Cushing syndrome by simply measuring the plasma cortisol. However, measuring plasma cortisol is difficult for a couple of reasons. First of all, cortisol secretion follows a circadian rhythm so that the levels are highest in the morning. The morning also happens to be when most labs are open and most patients want to go and get their blood tested. So a high level on a morning sample is difficult to interpret because it may be due to simple circadian rhythms or it may be due to the Cushing syndrome. In addition, most cortisol is bound to cortisol binding globulin, and cortisol binding globulin levels can fluctuate, and this can affect the total amount in the serum. There are a couple of ways to get around these problems. The first way is to do a 24-hour urine collection and measure the amount of free cortisol that is excreted. This basically integrates the cortisol level over time and gives you an estimate of how much cortisol is being produced per day by the patient. The second way is to measure the amount of cortisol in saliva. There's no cortisol binding globulin in saliva. This makes the level of cortisol in saliva less variable. In addition, the patient can collect the salivary sample at night and store it and bring it to the lab the next day. You can't do that with a blood sample, so the patient can spit into a cup and bring it to the lab the next morning, and you can measure the free cortisol level at night, and it should be low at night based on the circadian rhythms. Another way to make the diagnosis of Cushing syndrome is called the low-dose dexamethasone suppression test, and it's very high yield for you to understand how this test works for your board exams. Dexamethasone is a steroid. It has a similar structure to cortisol, and the patient takes an oral dose of 1 milligram of dexamethasone, that's a low dose, at bedtime. This will suppress the normal pituitary ACTH release because remember what I said, dexamethasone has a similar structure to cortisol, and it will block ACTH release just like cortisol, exerting negative feedback on the pituitary. The patient then goes to the lab in the morning and has a blood test, and the cortisol level should be very low because it was suppressed by the dexamethasone, which suppressed ACTH release. However, the cortisol level will be high if the patient has Cushing syndrome, and that's because adenomas and tumors do not suppress their cortisol production in response to dexamethasone. In other words, an adenoma in the adrenal gland will continue to secrete cortisol despite dexamethasone. Tumors in the pituitary gland or tumors in the lungs that are secreting ACTH will not respond to the low dose of dexamethasone, and thus in all of these situations the cortisol in the morning will remain high. The only situation in which the cortisol level will be low in the morning is if the patient has a normal hypothalamic pituitary adrenal axis. So step one in the workup of Cushing syndrome is to establish that the patient has Cushing syndrome. And you can do this by measuring urinary cortisol or salivary cortisol or by doing the low-dose dexamethasone test as I have just described. Step two is to establish the cause of Cushing syndrome, and in this case, the key test is the serum ACTH level. There are so-called ACTH-dependent causes, as I described a few slides ago, where the ACTH level will be high. These include Cushing's disease, which is a pituitary-secreting ACTH tumor, or an ectopic ACTH source like small cell lung cancer. Then there are other causes which are called ACTH-independent. These have a low ACTH. These include patients taking steroids for therapy and adrenal adenomas. Another test that can be used in the evaluation of Cushing syndrome is called the high-dose dexamethasone test. This test is similar but different from the low-dose dexamethasone test that we talked about 2 slides ago. In the low-dose test, a low dose of dexamethasone is administered in order to establish the diagnosis of Cushing syndrome. With the high-dose test, what is done is that a higher dose of dexamethasone is administered, usually 8 milligrams, and the idea here is to differentiate between causes of high ACTH Cushing syndrome. So if you administer a high dose of 8 milligrams and the patient's cause of Cushing syndrome is a pituitary adenoma, then cortisol production will be suppressed. In other words, when you measure the cortisol level after giving that high dose of dexamethasone, there will be less cortisol production. The reason for this is that pituitary adenomas respond to dexamethasone. They just have a high set point and they are overproducing cortisol, but you can suppress that cortisol production if you give enough of a dose of dexamethasone. In contrast, ACTH secreting tumors will not suppress. These tumors do not respond to high-dose dexamethasone, and therefore you will not see the cortisol ever decline after giving a high dose. So on the bottom of the screen here, I've shown a table where I've summarized the morning cortisol response after administering dexamethasone. When you give the low dose, normally the morning cortisol level will fall. If the patient has a pituitary adenoma or an ACTH secreting tumor, the level will not fall. When you administer a high dose, the level will fall if the patient is normal, of course. The level will also fall if there's a pituitary adenoma, but cortisol production will not decrease if the patient has an ACTH secreting tumor. The treatment for Cushing's syndrome is usually surgery. You remove the adenoma if there's one in the adrenal gland or the pituitary, or you remove the lung tumor if that's the source of ACTH. There is, however, one medicine that is sometimes used, and it's high yield for you to know this for your board, so let's talk about this now, and this is a drug called ketoconazole. Ketoconazole is an antifungal. It works by blocking ergosterol synthesis in fungi, and it has a chemical structure similar to the steroid hormones, and therefore it inhibits some of the enzymes involved in hormone synthesis. And one of those enzymes is the enzyme responsible for the first step in cortisol synthesis. That's called desmolase. It cleaves the side chain on cholesterol. If you look at the bottom left side of the screen, this is the structure of cholesterol. Desmolase cleaves this side chain, leaving behind a molecule of pregnenolone. Pregnenolone can then go through a series of steps to become cortisol. So by inhibiting desmolase, ketoconazole leads to a decrease in cortisol production from adenomas, and that's why it can be useful in treating Cushing's syndrome. Just a side note here, it also inhibits some of the enzymes involved in androgen synthesis, and for this reason, it can lead to low androgen levels, and that can cause gynecomastia in men, and that's a key side effect of this drug. So Cushing's syndrome is a syndrome of cortisol excess. Now we're going to talk about adrenal insufficiency, which is the opposite of Cushing's syndrome. This is what happens when there's insufficient cortisol production from the adrenal gland. Adrenal insufficiency can be a primary or secondary disorder. In primary adrenal insufficiency, there is a failure of the adrenal cortex. This is often called Addison's disease, named after the man who first described the condition. In primary adrenal insufficiency, cortisol and aldosterone can be low, but importantly, the ACTH level will be high. This is because the pituitary gland is reacting to the low cortisol level and trying to stimulate the adrenal glands, but they are unable to respond to the stimulation by ACTH. You can also have adrenal insufficiency due to a secondary cause. This is where the problem resides in the pituitary gland. It's failing to release ACTH. In this situation, the adrenal gland will fail to produce enough cortisol because it's not being stimulated. However, aldosterone production will be normal because aldosterone is under the control of the renin-angiotensin-aldosterone system. The symptoms of adrenal insufficiency can be subtle, and they're often missed clinically. All of the symptoms derive from either the loss of cortisol or the loss of aldosterone. The loss of cortisol leads to weakness and fatigue. It can also lead to weight loss. One of the classic symptoms of adrenal insufficiency is postural hypotension. You need cortisol to maintain a normal blood pressure. Patients who have adrenal insufficiency can have a slightly decreased or a low normal blood pressure when they're seated or lying flat. However, when they stand, their blood pressure will drop significantly and they can become dizzy and even sometimes pass out, and that's postural hypotension. Other symptoms include nausea, abdominal pain, and diarrhea. These often appear to be a GI illness, and in fact, adrenal insufficiency is often misclassified as a GI condition initially. And then finally, you need cortisol to maintain normal blood glucose levels, so in the setting of adrenal insufficiency, you can develop hypoglycemia. If aldosterone levels are also low, this can lead to potassium retention, which can lead to hyperkalemia. This can lead to acid retention, which can cause an acidosis, and it can also lead to sodium loss in the urine, which will be followed by water loss, and that will lead to symptoms of hypovolemia. Now, most of the symptoms of adrenal insufficiency are due to low cortisol levels, but there's one symptom that's due to high ACTH, and that's skin hyperpigmentation. Recall that ACTH is high in primary adrenal insufficiency, or Addison's disease, and this will lead to darkening of the skin, which is called skin hyperpigmentation. The reason for this is because melanocyte-stimulating hormone shares a common precursor protein in the pituitary with ACTH. If you look at this diagram on the bottom of the screen here, there is a precursor protein of ACTH and MSH that is made in the pituitary gland called pro-opiomelanocortin. It is split into ACTH and MSH, so when the pituitary is synthesizing lots of ACTH, in Addison's disease it will also synthesize lots of MSH, and the MSH will go and stimulate melanocytes, and that will increase melanin synthesis, and this will lead to darkening of the skin. You will not see this symptom in patients who have secondary adrenal insufficiency in which the ACTH is low. So Addison's hyperpigmentation is usually a generalized hyperpigmentation. These patients can look like they always have a suntan. It's most obvious in the sun-exposed areas like the face, neck, and the back of the hands. It's also classic for it to occur in areas of friction or pressure like the elbows, the knees, and the knuckles. Sometimes you can also see it in the palmar creases of the hands. Some of you may know that John Kennedy, whose picture is shown here, was President of the United States until his assassination in 1963, and he had Addison's disease, so he always looked like he had a tan, which people thought came from sailing on Cape Cod, but it actually came from his Addison's disease and ACTH. So a classic board scenario that you should be aware of is a patient who has GI symptoms like nausea and abdominal pain and also complains of darkening of the skin. These two should immediately make you think of Addison's disease. Adrenal crisis occurs when there is an acute drop in cortisol level and acute adrenal insufficiency. There's the abrupt loss of cortisol and aldosterone, and the main manifestation of this condition is shock. These patients will have low blood pressure and be in shock. They will also have very low blood glucose levels. They may have other symptoms that are less specific, like nausea and vomiting, fatigue, or confusion. And this often occurs when an acute increase in demand for adrenal function cannot be met. So for example, if a patient has adrenal insufficiency and they develop an infection or they go for surgery or they have trauma, they will develop acute adrenal insufficiency or adrenal crisis. This can also happen to patients who are on chronic steroids that suddenly stop their steroids. We'll talk about this in a minute, but the adrenal gland takes time to respond after you've been on chronic steroids, suppressing ACTH production. This is also the basis for stress dose steroids, which we'll also talk about in a minute, but when patients who have chronic adrenal insufficiency go for surgery, they're often given a single dose of high-dose steroids in order to prevent adrenal crisis. So let's talk about Addison's disease or primary adrenal insufficiency, and let's talk about some of the common causes for this condition. One of the first ones is an autoimmune disorder called autoimmune adrenalitis. This is an antibody and cell-mediated disorder. There are antibodies to the 21-hydroxylase enzyme, which are commonly seen. And the autoimmune destruction results in atrophy of the adrenal gland and loss of the cortex. Interestingly, the medulla is generally spared in this condition. It's just the cortex and the cortical hormones that are lost. Other reasons why you can have your adrenal gland fail include a number of infections. So tuberculosis classically infects the adrenal glands. Certain fungi, if they become systemic, can infect the adrenal glands, including histoplasmosis and cryptococcus. And finally, there are reports of cytomegalovirus also infecting the adrenal gland and leading to primary adrenal insufficiency. Here's a slide from our lung cancer module in the pulmonary section. I just want to remind you that the adrenal glands are a common site for metastasis of lung cancer. It's very high yield to remember this for your boards. It's very unusual for these metastases to cause adrenal insufficiency. Usually the metastases are found on imaging without symptoms or sometimes at autopsy, but you should definitely be aware for all of your board exams that the adrenal glands are a common location for metastases from lung cancer. A rare cause of adrenal insufficiency, but one you should definitely know about for your board exams, is the Waterhouse-Friderichsen syndrome. This causes acute adrenal insufficiency, and it's caused by hemorrhage into the adrenal glands, and it's strongly associated with meningococcemia. So you need to remember this condition if you see a patient who has bacterial meningitis and has the acute onset of shock. That person may have developed hemorrhage into their adrenal glands, and they may have acute adrenal insufficiency, and they need steroids if they're going to survive their meningococcus infection. On the last two slides, I've been describing causes of primary adrenal insufficiency where the problem lies in the adrenal cortex, but now let's talk about causes of secondary adrenal insufficiency. And in these disorders, the problem lies in the pituitary. It is not secreting enough ACTH to maintain cortisol production. The most common cause of secondary adrenal insufficiency is glucocorticoid therapy. Now, this may seem confusing because I told you a little while ago that chronic steroid therapy leads to Cushing syndrome, and now I'm saying it can lead to adrenal insufficiency. But the reason for adrenal insufficiency in patients on glucocorticoid therapy is that the steroids chronically suppress ACTH release from the pituitary gland. This can lead to adrenal atrophy over time. Basically, the steroids are doing the job of cortisol production and the adrenal gland is not doing anything, so over time it begins to atrophy. What this means is if the patient suddenly discontinues their steroid therapy, the adrenal gland cannot increase its production of cortisol in a timely manner, and this will lead to hypoadrenalism. This is the basis for weaning patients off of steroids. If patients have been on high dosages of steroids for several weeks or longer and they need to stop the steroids, you slowly discontinue them over time to give the pituitary gland time to slowly increase its ACTH production and time for the adrenal gland to take over the job of producing cortisol for the patient. This is also the basis for stress dose steroids, which I described a few slides ago. Patients who are on chronic steroids and develop an infection, a trauma, or they undergo surgery need increased amounts of cortisol, but their adrenal gland cannot rise to meet that demand because of the chronic suppression from their steroids, and there's a risk of adrenal crisis. So high-dose glucocorticoids are often administered, this is called stress dose steroids, to patients who are taking glucocorticoids chronically and who develop one of these conditions listed on the slide. Two important points about secondary adrenal insufficiency. There should be no skin findings in this condition, and that's because ACTH levels are not elevated. There also should be no hyperkalemia, and that's because aldosterone is not affected, and the renin-angiotensin-aldosterone axis is intact. There are a number of diagnostic tests that can be used to make the diagnosis of adrenal insufficiency. The first one is a morning serum cortisol level. Because of circadian rhythms, levels of cortisol should be highest in the morning, and if the level is low, this indicates disease. You can also measure the serum ACTH level. If it's high and the cortisol level is low, this suggests primary adrenal insufficiency. If the ACTH level is low with low cortisol, this suggests secondary disease. Another diagnostic test that's commonly used is to stimulate the adrenal gland with ACTH. There is a synthetic version of ACTH called concentropin, and in the concentropin stim test, you administer this exogenous ACTH and you measure the cortisol level 30 to 60 minutes later. It should rise. If it fails to rise from baseline, this suggests a primary adrenal insufficiency disorder. If there's a normal increase, it suggests a secondary disorder. Now let's talk about disorders in which there is isolated mineralocorticoid excess with no problems related to cortisol. These disorders are usually referred to as primary aldosteronism disorders. So if you have an elevated level of aldosterone, you will develop hypertension because one of aldosterone's effect is to lead to the resorption of sodium in water. Classically, the hypertension occurs at a young age in a person who you otherwise would not expect to have high blood pressure. There can also be hypokalemia because one of aldosterone's effects is to promote the excretion of potassium in the urine. This can present as weakness and muscle cramps. Importantly, this is an unreliable finding. Many patients with primary aldosteronism have normal potassium. If they eat enough potassium in their diet, the potassium level can remain normal. And then finally, you can have a metabolic alkalosis also from the high levels of aldosterone. This is a rare disorder, but when it does occur, the most common reason is bilateral idiopathic hyperaldosteronism. Basically, what this means is that both adrenal glands are producing too much aldosterone for unclear reasons. A less common cause is an aldosterone-producing adenoma, and this is sometimes referred to as Conn syndrome. You might think that you could diagnose this condition simply by measuring the plasma aldosterone concentration and showing that it is high. However, you have to remember that aldosterone levels go up in heart failure and many other conditions as part of the normal activation of the renin-angiotensin system. So to diagnose primary aldosteronism, you have to show not only that the aldosterone level is high, but also that the activity of the renin-angiotensin system is low. This will indicate that the adrenal gland is producing too much aldosterone without being stimulated. The way you evaluate the renin-angiotensin system is by measuring something called the plasma renin activity. In this test, you take a sample of plasma and you incubate it. Any renin in the sample will cleave angiotensinogen in the sample, and angiotensin 1 will be produced, and the level of angiotensin 1 can be measured by assay, and this is called the plasma renin activity. If you see a low level of plasma renin activity and a high aldosterone concentration, this indicates primary aldosteronism. If you see a high plasma renin activity and a high plasma aldosterone concentration, this indicates secondary aldosteronism. It means something is ramping up the renin-angiotensin system, and that could be renal artery stenosis or heart failure or low volume or any of the many causes of activation of the renin-angiotensin system. Other diagnostic tests include abdominal imaging to look for adrenal nodules or tumors, and then sometimes adrenal vein sampling is done. This is done by an interventional radiologist. A catheter is inserted into the left and then the right adrenal vein, and a blood sample is taken from each side. And this is done to differentiate unilateral versus bilateral disease. You can measure the aldosterone concentration and the renin activity in each vein, and sometimes you find that one vein has very suppressed levels of aldosterone and the other has very high levels, indicating that the problem lies on one side of the body. When the problem is confined to one adrenal gland, the treatment is surgery. You can remove one adrenal gland and leave the other, and this will take out adenomas or resolve unilateral hyperplasia. Another treatment that is very high yield for you to know about for step 1 is spironolactone. This is the drug of choice in primary aldosteronism. It is a potassium-sparing diuretic, but its mechanism of action is to block the effects of aldosterone. So obviously it is a drug you want to use when the patient has elevated aldosterone levels. You can also develop a syndrome that looks very much like hyperaldosteronism if you consume large amounts of the candy licorice. This is very uncommon, but this is the type of trivia question that your medical school professors love to ask you about. Licorice contains a compound called glyceretinic acid, which is a steroid, and it exerts a weak mineralocorticoid effect. The way it exerts its effect is by inhibiting an enzyme in the kidneys called 11-beta-hydroxysteroid dehydrogenase. If you look at the bottom of the screen, 11-beta-hydroxysteroid dehydrogenase converts cortisol into cortisone in the kidneys. Cortisol can stimulate aldosterone receptors, so this enzyme protects the kidneys by converting cortisol into cortisone, which is not a potent stimulator of aldosterone receptors. So therefore, if you consume lots and lots of the candy licorice and you inhibit this enzyme to a great degree, You can increase the exposure to cortisol in kidney cells, and this can lead to hypertension and hypokalemia. If you do a workup in patients like this, you will find that their plasma aldosterone level is low, even though they appear to have a hyperaldosterone syndrome, and that's because their syndrome is not from high levels of aldosterone, it's from eating too much licorice. I'll finish this module by discussing adrenal tumors, and we'll begin by talking about pheochromocytomas. So pheochromocytomas are catecholamine-secreting tumors. They can secrete epinephrine, norepinephrine, or dopamine. And importantly, especially for step 1, you should know that they are derived from chromaffin cells of the adrenal medulla. Obviously, because they secrete catecholamines, they are not going to come from the adrenal cortex. They are going to come from the adrenal medulla, which is where catecholamines are normally produced. And the adrenal medulla itself is a derivative of the neural crest, and therefore pheochromocytomas are also derivatives of the neural crest. One thing you should always remember about pheos is that the release of catecholamines is not constant from the tumor. It tends to release catecholamines in spurts, so the amount of catecholamines released goes up and down. Therefore, the symptoms are classically episodic, so patients will have episodes where they develop hypertension, headaches, palpitations, sweating, and sometimes pallor or pale skin, and all this is from a sudden burst of catecholamines released by the tumor. You might think that you could diagnose a pheochromocytoma by measuring the serum catecholamine levels, but in fact this is not routinely done, and the reasons are because, as I just said before, the levels fluctuate, and in addition, many of the catecholamines are metabolized inside the tumor, so you won't see high levels in the plasma. For this reason, what's usually done is to perform a 24-hour urine collection and look for the breakdown products in the urine of catecholamines. So in order to understand this, you need to understand how catecholamines are metabolized in the body. The two key enzymes for metabolism of catecholamines are monoamine oxidase, or MAO, and catechol-O-methyltransferase, or COMT. In terms of dopamine, what these two enzymes will do is metabolize dopamine into an intermediate and then finally metabolize it into homovanillic acid, or HVA. They can go in either order. Either MAO can metabolize it first and then COMT, or COMT first and MAO second, but either way you end up with homovanillic acid, or HVA. Norepinephrine and epinephrine are also metabolized by MAO and COMT, and just like dopamine, either MAO can go first or COMT can go first. So norepinephrine, for example, can be metabolized by MAO and then COMT, or it can be metabolized by COMT and then MAO. The same is true for epinephrine. The final breakdown product of both of these compounds is called vanillymandellic acid, or VMA. There are two important intermediates that you should note here. One is called normetanephrine, that is an intermediate of norepinephrine breakdown. The other one is metanephrine, which is an intermediate of epinephrine metabolism. So now that you understand that biochemistry, it should make sense to you that metanephrines are often used for the diagnosis of pheochromocytoma. You can measure the levels of metanephrine and normetanephrine. This is often done on a 24-hour urine collection, or sometimes it's done by a plasma blood test, but either way, you should appreciate that these are the breakdown products of metabolism of epinephrine and norepinephrine. An older test that's not used much anymore is a 24-hour urine collection of VMA, but that should also make sense to you, because as we just saw, vanillymandellic acid is a breakdown product of epinephrine and norepinephrine. The definitive treatment for pheochromocytoma is surgical removal of the tumor, but you should be aware that preoperative management of these patients is very important. During surgery, there's a risk of exposure to very high levels of catecholamines, and for this reason, patients are pre-treated with phenoxybenzamine. This is an irreversible alpha blocker, and it blocks all those alpha receptors so that no matter how many catecholamines the patient is exposed to during the operation, they will be safe. In addition, they're usually treated with a non-selective beta blocker like propranolol. You will sometimes hear the term paraganglioma. This is also a catecholamine-secreting tumor. It arises from the sympathetic ganglia, but it is extra-adrenal, and it has a similar presentation to a pheochromocytoma. It's basically an extra-adrenal pheochromocytoma. Neuroblastoma is another tumor of primitive sympathetic ganglion cells. These are also derived from neural crest cells, just like pheochromocytomas and paragangliomas, and these can arise anywhere in the sympathetic nervous system, but the adrenal gland is the most common location. 40% are found there, another 25% are found in the abdomen, and 15% in the thorax. And these almost always occur in children. Neuroblastoma is largely a tumor of children. It's the third most common childhood cancer after leukemia and brain tumors, and it's the most common extracranial tumor. The symptoms of a neuroblastoma usually relate to tumor mass effect, so it commonly presents as abdominal pain in a child. These tumors can secrete catecholamines, but unlike pheochromocytomas and paragangliomas, they rarely cause symptoms like hypertension and the other symptoms of pheos. You can, however, use urinary HVA and VMA levels for diagnosis. This is similar to the diagnosis of pheochromocytoma. You do a 24-hour urine collection and measure the levels of these breakdown products of catecholamines and use that for diagnosis. There's a rare clinical feature of neuroblastoma called opsoclonus myoclonus ataxia, or OMA. This is a rare paraneoplastic syndrome associated with neuroblastomas. It involves rapid eye movements, rhythmic jerking, and ataxia. And half of patients who have an OMA syndrome also have a neuroblastoma. So if you ever see a child described with this collection of symptoms, you should think that they might have a neuroblastoma. Neuroblastoma has a diverse range of disease progression. Some children are easily cured and others quickly die of their condition even with therapy. A very important risk factor is the age at diagnosis. For example, infants, even with disseminated disease, are often cured with surgery and chemotherapy. On the other hand, children over 18 months of age often die despite therapy. In general, the younger the age at diagnosis, the better the prognosis. Another important risk factor is alterations of the N-MYC gene. This is a proto-oncogene, and it is amplified or overexpressed in some tumors. And when amplification or overexpression of N-MYC occurs, this is associated with a poor prognosis. There is a special test that can be done for diagnosis of pheochromocytoma and neuroblastoma. It's called an MIBG scan. MIBG stands for meta-iodobenzyl guanidine, and it is a chemical analog of norepinephrine. This is the structure of MIBG shown at the top of the screen. At the bottom of the screen is norepinephrine. You can see that they look similar. So you can use MIBG for diagnosis of pheochromocytoma and neuroblastoma. Because it is similar looking to norepinephrine, it will concentrate in sympathetic tissues, and it is labeled with radioactive iodine, as I've shown at the top of the screen here. And the radioactive iodine will emit radiation that you can detect with a camera. So the MIBG will concentrate in the tumor, emit radiation, and then if you do a scan, you will see the MIBG locating to the place where the tumor is present in the body, and thus you can diagnose a pheochromocytoma or a neuroblastoma. A special note here that's high yield for you to know because it relates to thyroid physiology is that the thyroid gland must be protected during an MIBG scan. If the thyroid gland were to take up some of this iodine 131, it could destroy thyroid tissue. For this reason, during an MIBG scan, the patient is simultaneously administered potassium iodide. This is non-radioactive iodine, and it will be taken up by the thyroid preferentially instead of the radioactive iodine 131 that is present in the MIBG. I'll finish by talking about adrenal adenomas. These are small areas of hyperplasia found in the adrenal gland, and they're often discovered incidentally when abdominal imaging is performed for another reason. For example, when patients come to the ER with belly pain, they often have a CAT scan and an adrenal adenoma is discovered. It's often called an adrenal incidentaloma because it was discovered incidentally. And when you discover one of these, the concern is that it could represent malignancy or it could be functioning and secreting cortisol or aldosterone. So because these adenomas may secrete cortisol or aldosterone, a number of functional tests are often performed when an adrenal adenoma is discovered on an imaging study. And all of these functional tests should make sense to you now that we have gone through disorders of the adrenal gland. So you may order a 24-hour urine metanephrine test to exclude a pheochromocytoma. You may order a 24-hour urine-free cortisol to exclude Cushing's syndrome. Sometimes the low-dose dexamethasone suppression test is done. Remember, that's the test for Cushing's syndrome. And then finally, you may order a serum plasma renin activity and aldosterone level to rule out aldosteronism. If the tumor is non-functional and it's relatively small, it's often followed for growth over time. When they get large, such as over 5 centimeters, they are often removed out of concern that they may represent a malignancy. And that concludes our module on adrenal disorders.